Well, this is still a huge high-risk AML can be defined in several ways. I think the most commonly used method of defining high-risk AML is the ELN 2022 categorization, which basically takes people with what we have typically considered adverse cytogenetics, which is abnormalities of chromosomes 7 and 5, complex karyotype, as well as certain molecular abnormalities, including p53 mutations, ASXL1 mutations, and WT1 mutations. And these would all be considered high-risk AML in patients of any age who have one of these molecular or cytogenetic abnormalities. Some people think that any patient over the age of 75 or even 60 in some situations has high-risk AML, but if you want to limit the definition to people who are under age 60, I think we can pretty much well use the ELN 2022 high-risk definition of those who aren't going to fare very well with treatment. These patients do pose unique challenges because they don't seem to respond to chemotherapy, particularly the subgroup of patients with a p53 mutation who are at a high allelic burden p53 mutation, or will have p53 mutations with a complex karyotype or monosomal karyotype. These patients have a dismal outcome with chemotherapy. They have a dismal outcome even after, if they achieve remission, getting a transplant as consolidation. They seem to mostly relapse. So there are a number of efforts to find better therapies for these patients. The one therapy that people have chosen to think about most strongly probably is Magrolimab, an anti-CD47 antibody that covers up a don't eat me signal. But the long-term data on the use of Magrolimab or other anti-CD47 blocking antibodies remains too early to say whether this is really a boon or not.